Welcome back to the deep dive. Today we are undertaking a really foundational exploration into what is probably the most pervasive system in the entire body.
Oh, absolutely. The hematologic system.
Exactly. And we've drawn on some deep research specifically from Chapter 28 of Brunner and Sutterth's Medical Surgical Nursing to give you, well, a step-by-step masterclass on it all. Assessment, diagnostics, the whole thing.
And, the reason this is so crucial is that blood it's the connective tissue for everything.
Yeah.
It's moving oxygen, it's fueling your immune system, it's controlling bleeding.
Yeah.
But here's the real clinical mission for us today. A lot of major hematologic issues, things like subtle anemia or even early leukemia, they don't always show up with big dramatic symptoms.
Right.
They often start as these quiet little abnormalities in the lab work. And a really well-prepared nurse has to be able to see those signs, anticipate what comes next, and get ahead of it.
That completely shifts the paradigm, doesn't it? We're not just reacting to a crisis.
You're predicting one.
So we've structured our journey today to build that knowledge piece by piece. We're going to start with the bedrock, really understanding the mechanics of how blood cells are made, hematopoiesis, and how bleeding is stopped, hemostasis.
And from there, we'll move right to the clinical bedside. We'll detail the health history you need to take and the specific physical assessments that can tip you off to an underlying blood disorder.
Including what genetic factors to ask about.
Then we get into the diagnostic phase. We'll break down the CBC, the peripheral smear, and those really high-stakes procedures like a bone marrow biopsy, and, of course, the nursing care that goes with them.
And we'll finish up with the therapeutic side, surgical, pharmacologic, and the world of blood component administration.
Which is where the nurse really becomes that final safety monitor, making sure that this life-saving therapy is delivered without a single incident. So let's jump in.
Okay, let's unpack this system, what it is, what it does. Our sources describe blood as a specialized organ. It's kind of a weird way to think about it.
It is, but it's accurate. It's unique because it's a fluid.
Yeah.
And it's a huge part of us. It makes up about 7 to 9% of our total body volume.
Up to 9% of your body weight is this fluid. Wow.
Yeah, and if you look at its composition, it's split almost down the middle. About 55% of it is plasma. That's mostly water, but it's got these crucial proteins floating around in it.
And these plasma proteins are the real workhorses, right? Like albumin.
Absolutely. Albumin is essential for maintaining oncotic pressure. That's the force that, keeps fluid balanced inside your vessels instead of leaking out into your tissues.
Then you have globulins for immunity,
Right.
And fibrinogen, which is, that's the precursor for clotting.
Exactly. And the other 40 to 45%, that's your cellular components. The red blood cells, white blood cells, and platelets.
And the factory for all of this is the bone marrow.
The bone marrow, which is itself enormous, 4 to 5% of our body weight. But the actual site of hematopoiesis, where the blood cells are actively being made, it's pretty localized in adults.
We're talking mainly the pelvis, ribs, vertebrae, and the sternum.
That's right. Structurally, you've got this active red marrow, which is packed with cells, and then yellow marrow, which is mostly fat. And as we get older, that red marrow gets replaced by fat. It's part of why older adults have less physiological reserve.
But the body's engineering is just, it's incredible, because if that active marrow is compromised, say, from a plastic anemia or fibrosis, which is like scarring.
The body has a backup plan.
It does.
And this is a really surprising fact our sources highlight. It's a process called extramedullary hematopoiesis.
Meaning outside the marrow.
Right. The liver and the spleen, which produce blood cells when we were fetuses, can actually jump back in and restart production. It's a huge clinical clue, because if you see an enlarged liver or spleen in an adult, you have to wonder if their bone marrow is failing.
That's fascinating. So if we zoom right into the heart of the marrow, we get to the stem cells. They're described as pluripotent.
Pluripotent, yeah. It means they can do two things. They can continuously self-replicate to maintain their own population, and when they get the right signal, they can differentiate into something else.
And this differentiation, this fork in the road, it's the key to understanding basically all hematologic disorders.
It's everything. The stem cell makes a choice. It either goes down the myeloid stem cell line or the lymphoid stem cell line.
Okay, let's talk about the clinical implication there. The myeloid line it's the massive production factory.
It is. It's making your red blood cells, your platelets, macrophages, and most of your white cells. The neutrophils, eosinophils and basophils.
So,
So if you have a disease like myelodysplastic syndrome that hits that myeloid stem cell, you don't just get one problem, you get pancytopenia.
low everything.
Low everything. You get anemia from low RBCs, bleeding from low platelets, and infection from low neutrophils. It hits the whole system at once.
And the lymphoid side.
The lymphoid stem cells are much more focused on that specific adaptive immune response. They're producing your T and B lymphocytes, plasma cells, and natural killer cells. A defect there, like in lymphoma, is going to target your immune defenses, not so much oxygen or clotting.
And we can't forget the support staff in the marrow, the stroma.
Right. The fibroblasts, osteoclasts, they form the matrix. And they're so important because they produce the chemical signals, the colony-stimulating factors, or CSFs.
The growth factors.
Exactly. They regulate which cells get made and how many. Without the stroma sending the right signals, the stem cells can't do their job. We actually use synthetic versions of these as drugs.
So if we zoom all the way back out, blood is the body's delivery system. Oxygen, nutrients, hormones, antibodies.
And it's also the waste management team. It carries metabolic byproducts away to the lungs, liver, and kidneys to be eliminated.
And central to all of this is hemostasis.
Hemostasis. It's this beautiful, delicate life or death balance between forming a clot to stop you from bleeding out and dissolving that clot so it doesn't cause a stroke or a PE. It's a constant balancing act.
All right, let's shift focus to the red team, the erythrocytes. They're the most abundant cell, and their structure is just perfectly designed for their job. It's a biconcave disc, like a squished sphere.
That shape is pure genius. It maximizes the surface area for gas exchange, and its flexibility lets that 8 micrometer cell squeeze through capillaries that are less than 3 micrometers wide.
So if it loses that flexibility,
That's the signal that it's old.
Yeah.
That's how the body knows it's time for it to be removed from circulation.
and 95% of the cell's mass is hemoglobin, that protein with iron that carries the oxygen. The fact that mature RBCs don't have a nucleus is a big deal, too.
Huge. It means they can't repair themselves or replicate. They have a finite lifespan.
And the oxygen transport is a reversible bond. Oxygen binds to the iron, forming oxyhemoglobin, that's the bright red of arterial blood.
Right. And once it drops off the oxygen in the tissues, it's not done working. It then acts as a buffer, picking up excess hydrogen ions and CO2 to carry back to the lungs.
So when the body needs more oxygen, the marrow just ramps up production. We see these slightly immature RBCs, reticulocytes, released into the circulation.
And that reticulocyte count is such a key diagnostic clue for a nurse. A high count tells you the marrow is responding like it should, maybe after a bleed. A low count, even when the patient is anemic. Well, that suggests the factory is failing, or it's missing its raw materials.
Speaking of production, let's talk erythropoiesis. This is regulated mainly by the kidney, right? Through the hormone erythropoietin.
Exactly. The stimulus is simple. Hypoxia, low oxygen. The kidney senses low oxygen from anemia, lung disease, even high altitude, and it releases erythropoietin. That hormone tells the marrow, hey, we need more red cells now, and the process takes about a week.
This is why patients with chronic kidney disease get so anemic.
It is. Their kidneys just can't produce enough of that signal.
Now, to build a proper RBC, you need 3 non-negotiable ingredients. Let's start with iron.
Iron is very tightly controlled. It's stored as ferritin, transported by transferrin. But our sources point out a huge nursing alert about iron deficiency. In a child, it might be nutritional.
But in an adult?
In an adult, you have to assume it's from chronic, slow blood loss until you prove otherwise.
That is a massive clinical takeaway. So if you see an adult male or a postmenopausal woman with iron deficiency, you're not just thinking, eat more spinach.
No. You are immediately thinking about a GI bleed, an ulcer, or more ominously, colorectal cancer. The nurse's job is to advocate for that workup, not just hand out iron pills.
Absolutely. The other 2 essentials are vitamin B12 and folate. Both are needed for DNA synthesis.
And their deficiencies look different because of how we store them. Folate stores are pretty small. A bad diet, say from chronic alcoholism, can deplete your reserves and cause anemia in just a few months.
But B12 is trickier.
Much trickier. It needs a special protein called intrinsic factor, which is made in the stomach, to be absorbed. So if you have stomach issues or you've had gastric surgery, you can't absorb it.
And what's wild is that the body stores years' worth of B12.
2 to 4 years. So if your production of intrinsic factor stops today, it could be years before you actually see the symptoms.
And whether it's B12 or folate deficiency, the result is the same. A problem with DNA synthesis.
Right, which leads to these abnormally large, fragile cells called megaloblasts. Many of them die in the marrow, and the ones that get out don't work well. That's megaloblastic anemia.
And at the end of their 120-day lifespan?
They lose their elasticity, get trapped, and are filtered out by the reticuloendothelial system, or RES. It's mostly macrophages in the liver and spleen. The body is great at recycling the iron. The rest of the heme breaks down into bilirubin, which gets secreted in bile.
Which is why if you're breaking down too many RBCs hemolysis, your bilirubin goes up and you get jaundiced. Okay, let's switch gears to the defense system, the leukocytes, or white blood cells. The normal count is somewhere between 4,000 and 11,000. Their job is clear: protect against infection.
And they're mainly organized by their structure. The granulocytes are the majority, 60 to 80%. They have these visible granules in their cytoplasm. That group includes neutrophils, eosinophils, and basophils.
Neutrophils are the true first responders, aren't they? The main phagocytes for bacterial infections.
They are. We often call them PMNs or SEGs. And when there's a serious bacterial infection, the nurse needs to be watching the labs for a left shift.
What does that mean, a left shift?
It means the bone marrow is getting desperate. It's pushing out slightly less mature forms called band cells to fight the infection. A rise in band cells is a huge clinical sign that the body is fighting something serious.
And they're powerful, but they don't live long.
Very short-lived. They're in circulation for maybe 6 hours before they move into the tissues, do their job for a day or two, and then they die. It's a rapid turnover system.
Then you have the agranulocytes, monocytes, and lymphocytes.
Right. Monocytes are the biggest leukocytes. They circulate for a bit, then move into the tissues and transform into macrophages.
And macrophages are the cleanup crew.
They are the sustained fighters. They handle long-term phagocytosis against things like fungi and viruses, and they're critical for digesting old blood cells and cellular junk.
Lymphocytes are the core of our immune memory. T cells for cell-mediated immunity.
Right. They directly attack and kill foreign cells, like cancer cells. They're also responsible for rejecting a transplanted organ.
And B cells are for humoral immunity.
They differentiate into plasma cells, which are antibody factories, just pumping out immunoglobulins to neutralize pathogens.
And we can't forget the natural killer, or NK cell.
Definitely not. They are potent killers of virus-infected cells and cancer cells. They also help mobilize the T and B cells.
And just to round out the granulocytes, we have eosinophils and basophils.
Both are big players in hypersensitivity reactions. Eosinophils neutralize histamine and attack parasites, while basophils are basically little histamine grenades, releasing it to start the inflammatory response.
Okay, now for the smallest players, the platelets or thrombocytes, they're just fragments of giant cells in the marrow called megakaryocytes.
Regulated by the hormone thrombopoietin. And what's interesting is that only about 80% are circulating. The other 20% are just held in reserve in the spleen, ready to go.
And they only live for about a week.
7 to 10 days. But their job is immense. They maintain the vessel lining, they form that first temporary plug when you get injured, and they kick off the entire clotting cascade.
Which brings us back to hemostasis and that incredibly complex clotting cascade. The first thing that happens is vessel constriction.
Right. Reduces blood flow to the area. Then you have primary hemostasis. This is the quick mechanical fix. Platelets rush in, stick to the exposed collagen in the vessel wall, and form this unstable plug. It's like putting a piece of tape over a leak.
Then comes secondary hemostasis or coagulation. This is the chemical stabilization part.
Exactly.
Yeah.
This is where a whole series of inactive clotting factors get converted into active forms, right on the surface of that platelet plug. The end result is fibrin, which is like a strong mesh that makes the clot stable.
And the activation happens through two different pathways, which is a really critical distinction for us clinically.
It's everything. You have the extrinsic pathway, which is the fast one. It gets activated immediately by tissue factor when tissue is damaged.
And then the intrinsic pathway.
The intrinsic pathway is slower. It's activated when blood comes into contact with exposed collagen inside a vessel. And this distinction matters because of our lab tests.
Tell us more about that. How does it link to our clinical practice?
Well, the prothrombin time, or PT, which we standardize as the INR,
Right.
that primarily measures the extrinsic pathway.
Yeah.
That's the one we're watching when a patient is on an oral anticoagulant, like warfarin.
And the APT.
The activated partial thromboplastin time measures the integrity of the intrinsic pathway. That's the one we monitor when a patient is on intravenous heparin. Knowing which test goes with which pathway and which drug is just, it's fundamental nursing knowledge.
And once the vessel is healed, we need to get rid of that clot. That's fibrinolysis.
Right. You don't want the clot sticking around forever. A protein called plasminogen gets woven into the clot as it's forming. When it's activated, it turns into plasmin. And plasmin is the enzyme that just dissolves the fibrin mesh, breaking it down into harmless little pieces.
Okay, before we get to the bedside assessment, let's talk about the impact of aging, this idea of immunosescence.
Yeah, as we age, the bone marrow's ability to respond to stress it goes down. That reduced reserve means older adults are more likely to become anemic or leukopenic when they get sick.
And it affects the immune system directly, too. T and B cell development is slower.
It's less robust. It means they might struggle to mount a really effective defense against an infection or even a malignancy. It's something you have to keep in the back of your mind when you're assessing a febrile elderly patient.
So let's transition to that nursing assessment. It has to be incredibly thorough because these problems can be so subtle at first. The health history is where you start digging for clues.
And the single most common symptom you're looking for?
Fatigue.
Extreme, pervasive fatigue. It's the hallmark of anemia. But you also ask about easy bruising, delayed clotting, nosebleeds, heavy menstrual periods, joint pain.
And our sources highlight chart 28:1, which stresses the need to assess genetic and ethnic factors. You can't just ask if someone in the family had anemia.
No, you have to be specific. You ask about factor V Leiden, a clotting disorder. You ask about hemophilia, sickle cell, thalassemia. These are all strongly linked to family history and ethnicity.
And of course, a full medication and nutritional review.
It's non-negotiable. You're looking for those B12, folate, or iron deficiencies, but you're also scrutinizing their med list, including over-the-counter stuff like garlic or ginkgo, which can mess with platelet function and increase bleeding risk.
So on to the physical assessment. Table 28:2 guides us here. The skin is the first big window into what's going on.
Always. You look for pallor, a classic sign of anemia, jaundice, which points to hemolysis. You might even see a gray or bronze skin color, which is classic for hemochromatosis iron overload.
And a ruddy, flushed look could be polycythemia.
Exactly, an overproduction of red cells.
And what are the subtle signs of bleeding we should be looking for?
Petechiae. Those are tiny, pinpoint red or purple dots that don't blanch when you press on them. They often show up on the lower legs or trunk and are a huge red flag for low platelets. You also look for large, spontaneous bruises or ecchymosis.
Okay, moving to the mouth. What's relevant there?
Well, you can see petechiae on the mucous membranes. But the classic sign of a severe B12 or folate deficiency is a smooth, shiny, beefy red tongue, often with little cracks at the corners of the mouth called angular chylosis.
And we also need to palpate the lymph nodes.
All the accessible sites, pericular, axillary, inguinal. You're feeling for size, tenderness, and mobility.
What's the difference?
Well, hard, fixed, non-tender nodes can be very suspicious for a malignancy, like lymphoma, whereas tender, mobile nodes are more likely just from an acute infection.
And on the abdominal exam, we're checking for an enlarged spleen or liver.
Right, which could mean they're filtering out too many cells, or that extramedullary hematopoiesis we talked about is kicking in because of a serious underlying disease.
Finally, those constitutional symptoms, unexplained fevers, chills, drenching night sweats.
Often the first systemic clues of something like lymphoma or leukemia.
Okay, let's get into the lab work. Starting with the CBC, the complete blood count.
The CBC gives you the total counts for everything: white cells, red cells, platelets, plus hemoglobin and hematocrit. But just as important are the RBC indices, like the MCV, which tells you the average size of the red cells.
So you can tell if the anemia is microcytic, like from iron deficiency, or macrocytic from B12 or folate deficiency.
Exactly. But the CBC printout is not the final word. Our sources really stress the need for a peripheral blood smear.
That's where a person actually looks at the cells under a microscope.
Right. This manual look at cell morphology, the shape, the size, the appearance, is crucial because it can spot abnormalities that the automated counters miss. It can help tell the difference between sickle cell and thalassemia, or different types of leukemia.
Then we have the coagulation tests we mentioned, the PTINR and APTT. What's the critical nursing precaution when you draw blood for those?
This is a huge safety alert. The collection tube has to be filled with the exact right amount of blood. The anticoagulant in the tube is proportional to the volume. If you underfill or overfill it, the ratio is off and you'll get dangerously inaccurate results.
Which could lead to someone getting way too much or too little anticoagulant.
Precisely. Accuracy in the draw is everything.
Now for the most invasive tool, the bone marrow aspiration and biopsy. This is the only way to really look inside the factory.
It's to assess the quantity and quality of the cells being made, look for abnormal cells, or find an infection or tumor in the marrow itself. The safest and most common site is the posterior iliac crest.
And nursing preparation here is key because Patients are often terrified of this procedure.
You have to go beyond just getting consent. You have to educate them on exactly what they're going to feel. You start by numbing the skin and the periosteum, the covering of the bone,
Mm,
when the needle goes in for the aspiration.
liquid part.
Right. The patient will feel a sharp, intense, but very brief pain as the suction is applied. Your job as the nurse is to coach them through that moment.
And for the biopsy, the solid core sample, the feeling is different.
It is. The patient should feel a deep, intense pressure, a pushing sensation, but not that sharp suction pain. If they feel sharp pain during the biopsy, you need to stop and tell the provider. They may be more anesthetic.
And post-procedure care is all about preventing bleeding.
All about it. You apply firm pressure for several minutes, put on a sterile dressing,
Yeah.
and the patient cannot take aspirin or any NSAIDs. No rigorous activity for a day or two. Bleeding and infection are your main risks.
Okay, now that we know how to assess and diagnose, let's talk about interventions. Starting with surgery, the splenectomy.
So the spleen's job is to remove old or damaged cells. But in some diseases, like ITP or certain hemolytic anemias, the spleen, it just goes rogue. It gets enlarged and starts aggressively destroying perfectly healthy red cells or platelets.
So removing the spleen removes that mechanism of destruction,
Exactly.
but taking out a major immune organ has to come with risks.
Oh, big time. Acutely, there's the risk of hemorrhage. Long-term, the number one concern is overwhelming, life-threatening infection. Without the spleen, the body has a really hard time fighting off encapsulated bacteria.
Like pneumococcus.
Pneumococcus, meningococcus. So the nurse has to prioritize education about lifelong infection prevention. These patients need an aggressive vaccination schedule and sometimes even prophylactic antibiotics.
Okay. Next up is therapeutic apheresis.
The word literally means to take away. It's a machine that separates the blood, removes a specific component, and gives the rest back to the patient.
And table 28.3 shows how versatile it is. If someone has way too many platelets, thrombocytosis, you can do plateletpheresis to remove them.
Or leukapheresis for way too many white cells in certain leukemias. Erythrocytopheresis, or red cell exchange, is a lifesaver in severe sickle cell disease. And plasmapheresis removes plasma, which is used for hyperviscosity syndromes.
Apheresis is also used before a hematopoietic stem cell transplant, or HSCT.
Right. HSCT is a potentially curative, but really intense therapy for severe marrow disorders like leukemia or plastic anemia.
It involves wiping out the patient's diseased marrow and then giving them a transplant of healthy stem cells.
And we distinguish between allogeneic, which is from a matched donor, and autologous, using the patient's own cells that were harvested when they were in remission.
Then there's a much simpler intervention, therapeutic phlebotomy. It's just the controlled removal of a unit of blood.
And this is the main treatment for conditions of overproduction. Patients with polycythemia vera, who make too many red cells, get phlebotomy to lower their hematocrit and reduce clotting risk.
And for hemochromatosis, where they absorb too much iron?
Right. Regular phlebotomy actually induces a controlled iron deficiency, which prevents that iron from depositing in organs like the heart and liver and causing damage.
And that brings us to the final major therapy, blood component therapy.
Right. We start with whole blood, but we separate it into components for maximum benefit. And as table 28-4 shows, the storage requirements are everything.
Packed red blood cells, or RBCs, are concentrated and stored in a fridge at 4 degrees Celsius. They last up to 42 days.
But platelets are incredibly delicate. You can't refrigerate them. They have to be stored at room temperature with constant, gentle agitation to stop them from clumping. And they only last for 5 days.
Which makes managing the inventory a huge challenge.
A nightmare. And fresh frozen plasma, or FFP, is frozen immediately to preserve all the clotting factors. It has to be thawed right before you use it.
And our sources highlight a key safety point for special products like albumin or IVI.
Yeah, these are unique because they could be heat-treated to 60 degrees Celsius to kill any viral contaminants. You can never do that to RBCs or platelets. It would completely destroy them.
All right, this final section has so much critical information for the nurse. The moment that blood is ready for infusion, the nurse becomes the primary guardian of patient safety. Let's start with how we get the blood.
The donor criteria are very strict. Minimum weight of 110 pounds, a certain hemoglobin level, and a screening process for travel, risks, all of it.
And we see different kinds of donations. What about directed donation, where a family member donates for the patient?
It's actually discouraged by most blood centers. It's often no safer than a random donation because that family member might feel pressured and not be totally honest about their risk factors.
So the gold standard for safety is autologous donation, using your own blood.
For an elective procedure, yes. Zero risk of viral transmission. The downside is it takes planning, resources, and it might not be enough if there's a major unexpected bleed.
There are also intraoperative methods, like blood salvage.
Right? Suctioning blood lost during surgery, washing it, and giving it right back. It's great, but you can't store it.
And hemodilution.
Where you remove a unit or two of the patient's blood before surgery and replace the volume with saline. The idea is that any blood they lose during the procedure is more dilute, so they lose fewer actual red cells.
The safety of the blood supply is incredible. Every unit is tested for HIV, hepatitis B and C, syphilis.
And the key technology here is nucleic acid amplification testing, or NAT.
What does that do?
It detects the virus's actual genetic material, which drastically shortens the window period between when someone gets infected and when they test positive. It has made the risk of transmission astronomically low, like 1 in 1.6 million units for HIV or HCV.
Then, once it's cleared, it's typed for the ABO system and the RH system. Compatibility here is non-negotiable.
Absolutely not. And then there are two more processing techniques to reduce risk even further. The first is leukocyte filtration, making the blood leukophore.
And this is so important because most of the common non-hemolytic transfusion reactions are caused by the recipient's antibodies attacking the donor's white blood cells.
Exactly. Filtering them out dramatically reduces the risk of those febrile reactions. It's standard practice for anyone who gets transfusions long-term.
The second is irradiated blood.
It's exposed to low-level radiation to neutralize the donor's T lymphocytes. This prevents a fatal condition called transfusion-associated graft versus host disease, where the donor's immune cells attack the immunocompromised recipient's body, essential for stem cell transplant patients.
Okay, let's get to the most crucial nursing step. The pre-transfusion assessment. A thorough history is vital.
You have to ask about prior transfusions and any reactions, no matter how minor.
And specifically for female patients, you ask about the number of pregnancies. Why is that?
Because during pregnancy, the immune system is exposed to foreign antigens from the fetus. This increases the chance that they've developed antibodies that could react with donor blood.
Then you need a full baseline assessment, vitals, temperature, and you have to pay close attention to fluid status.
You're listening for crackles in the lungs, checking for a high heart rate, jugular venous distension. If your patient is already fluid overloaded, you have to anticipate the risk of TACO.
And you have to educate the patient.
Non-negotiable. They have to know the signs of a reaction. Itching, hives, fever, chills, low back pain, shortness of breath. We're just feeling weird or different. The patient is your best first alert system.
Then comes the procedure itself. Charts 28-3 and 28-4 are all about this, and the number one priority is preventing clerical error.
Because that is still the #1 cause of fatal reactions.
Which means the mandatory life-saving double check. A second qualified person.
At the bedside. That's the part people forget. It has to be at the bedside, right before you spike the bag. You verify the patient's ID with 2 identifiers, the blood tag, the ABO and RH type, the expiration date, all of it.
And PRBCs have to be started within 30 minutes of leaving the blood bank. You start slowly, no more than 5 milliliters per minute for the first 15 minutes while you're right there watching them.
And the whole infusion can't take more than 4 hours because of the risk of bacterial growth. And you never, ever add medications to the blood.
Platelets and FFP are a bit different.
Yeah, platelets you infuse as fast as the patient can tolerate to keep them from clumping. FFP is usually over 30 to 60 minutes. But for both, you're watching very closely for circulatory overload.
Okay, now for the 7 major transfusion complications. This is high stakes, need-to-know information for every nurse.
And your ability to tell them apart by their symptoms and timing is what lets you make the right emergency response.
Let's start with the most common one.
Febrile non-hemolytic reaction. This is from the recipient's antibodies attacking the donor's white cells. The patient gets chills, then a fever spike of more than 1 degree Celsius, usually within 2 hours of starting.
Management is stopping the transfusion, but you want to avoid giving routine Tylenol for future transfusions.
Right, because it can mask the start of a much more dangerous reaction. Using those leukocyte-reduced filters is the best prevention.
Okay, now for the most dangerous one.
Acute hemolytic reaction. This is almost always from ABO incompatibility, which means, tragically, a clerical error. It causes massive, rapid hemolysis inside the vessels.
And the symptoms are fast and severe. Fever, chills, chest tightness, low back pain.
That flank pain is from the kidneys getting slammed with all that cellular debris. And the classic sign is hemoglobinuria, dark, red, or brown urine. It leads to hypotension, DIC, and acute kidney failure very quickly.
Next is the allergic reaction.
This is a sensitivity to plasma proteins. A mild reaction is just hives and itching. If it's mild, you can stop the transfusion, give an antihistamine, and if it resolves, you might be able to restart it slowly. A severe reaction is bronchospasm and shock, which needs epinephrine.
Then we have the two big fluid-related complications. First, transfusion-associated circulatory overload, or TACO.
This is just pure hypervolemia. You've given too much fluid too fast for the patient's heart or kidneys to handle.
And the symptoms are what you'd expect: shortness of breath, tachycardia, JVD, and crackles in the lungs. And it can happen up to 6 hours after the transfusion is done.
The management for TACO is to slow the infusion, sit the patient upright with their feet hanging down, and get orders for diuretics and oxygen.
Now, contrast that immediately with the other life-threatening lung reaction, transfusion-related acute lung injury, or TRALI.
And this is the single most common cause of transfusion-related death. It's an acute lung injury that happens within 6 hours.
And TRALI is not about volume overload.
Not at all. It's an immune reaction. Donor antibodies attack the recipient's leukocytes, which causes massive capillary leak and non-cardiac pulmonary edema. The symptoms are severe shortness of breath, profound hypoxia, hypotension, and fever.
And the critical nursing distinction here
Is that, unlike TACO, where you give diuretics and CRLNI, diuretics are contraindicated. They can make the hypotension worse. Management is aggressive, supportive care, oxygen, often intubation, and blood pressure support.
Then we have the risk of bacterial contamination.
Much higher risk with platelets because they're stored at room temperature. The symptoms are dramatic. High fever, shaking chills, sudden hypotension.
And if you suspect it,
You stop the transfusion immediately. The patient needs rapid fluid resuscitation and broad-spectrum IV antibiotics right away to prevent septic shock.
finally, the delayed hemolytic reaction.
This happens up to 14 days later. It's a slower extravascular hemolysis. The patient might have a mild fever, unexplained anemia, and jaundice. It's usually mild, but you have to recognize it so it doesn't happen again.
And for patients getting long-term transfusions, we have to talk about iron overload.
Yes, as Table 28-5 explains, every unit of PRBCs has about 250 milligrams of iron. The body can't get rid of excess iron, so it deposits in the heart, liver, and pancreas, causing organ damage.
So the key nursing intervention is to educate them about and ensure they start iron chelation therapy.
It's a drug that binds to the excess iron so the body can excrete it. It's life-saving for these patients.
So to summarize the absolute essential nursing steps for ANI suspected reaction.
Number 1, stop the transfusion immediately.
Number 2, maintain the IV access, but with new tubing and normal saline at a slow rate.
Number 3, assess your patient. Compare their vitals to the baseline. Check their respiratory status. Look for signs of shock.
Number 4, notify the provider and the blood bank. Carry out any emergency orders.
And number 5, send everything back to the blood bank. The blood container, the tubing, a new blood sample from the patient, and a urine sample. They need all of it to figure out what went wrong.
And we should remember there are pharmacologic alternatives too, the growth factors.
Right. Erythropoietin, or epoetin alpha, stimulates red cell production. We use it for chronic anemia, but we have to be careful to keep the hemoglobin below 12 to prevent thrombosis.
And for the white cells, we have G-CSF, or filgrastim.
Which stimulates the myeloid stem cells. We give it to prevent infection in patients with neutropenia from chemo. The nurse should anticipate and manage the main side effect, which is bone pain.
And for platelets, the newer TPO agonists.
Exactly. They stimulate platelet formation for conditions like chronic ITP.
That was an incredibly thorough deep dive. We started with a single stem cell and ended with the safety checks at the bedside. We've covered cell lines, assessment, and all 7 of those crucial transfusion complications.
I think for you, the learner, the key takeaways are all about prioritization and nuance. Remember that the double check at the bedside isn't just a policy. It is a life-saving intervention to prevent clerical error. Meticulous adherence to that process is it's non-negotiable.
And your ability to triage those pulmonary symptoms is paramount. Knowing the difference between the volume overload of TACO, where you need a diuretic, and the immunologic leak of TRALI, where diuretics are harmful. That is the definition of expert nursing in this field.
We really look at the whole cycle, from hematopoiesis to fibrinolysis. And given that hemostasis is this constant, life-sustaining balance between bleeding and clotting, let's leave you with this final thought. When you encounter a patient with a sudden, massive change in that balance, either an acute hemorrhage that needs massive transfusion or a severe, unexpected clot like a massive PE, what immediate diagnostic and therapeutic steps will you prioritize first to restabilize that essential equilibrium, even before the labs come back? Think about how you apply that foundational knowledge in a real acute crisis.